Alrighty, my name is Emily Nystrom, and this is my capstone synthesis project. For my capstone, I had the opportunity to be in the ICU float pool at Essentia. I was able to be on both the cardiac ICU and the neurotrauma ICU. When it comes to demographics of the floor, we had critically ill patients who typically were older than 50. A majority of them were 20 to 50, and then very rarely are there ever patients under that 20 years old. Um, but it does sometimes happen. Most of the reasons why the patients are there, I'm going to kind of split them into CVICU and NTICU because I feel like the reasons are a lot different. So for the CVICU, um, cabbage surgeries were a big reason why patients were there, mainly to watch for post-op complications after those surgeries. Any type of cardiogenic shock that required more than just one pressor, any type of bad heart block, like a bundle block branch or a third degree heart block, and then any MI that TNK was used, they typically end up on this floor. Sometimes they're IMC status, but mainly they're ICU. Any type of cardiac arrest would also come to this floor. We've also had a lot of valve replacement patients, balloon pump patients, and then any patient overall who is on a vent, they would also come to this floor. For the neurotrauma ICU, stroke patients who are actively having strokes, any patient who has received TNK typically goes to the ICU for at least that 24-hour period. Any type of TBI or traumatic incident that results in brain bleeds of any sorts. Burn patients. This floor also had a lot of septic shock patients that required pressors to increase their heart rate or increase their blood pressure. We had a lot of vented patients that were on vents due to more neurological issues. I saw a few spinal cord injuries from NVAs, and then we also had a lot of seizure patients or patients who overdosed and they're worried about them having seizures. And then lastly, any patient who is requiring a BiPAP or heated high flow are also commonly on this floor. The type of labs and stuff that we see done pretty much see everything. A lot of TEEs, echoes, ultrasounds, CBCs, BMPs, coag studies, pretty much any type of lab you can think of, they do on the ICU floors. CT scans, we do bring patients down to MRIs, X-rays happen at the bedside, continuous EKGs are also done, biopsies, ultrasounds, and really so much more. Um, when it comes to the general nature of the floor, there is a lot of friends and family with each of the patients. They play kind of a bigger role in the ICU setting because a lot of our patients are intubated and sedated and unable to make their own medical decisions. So the families do make the medical decisions for them. Um, Moving on. When it comes to my patient, I'm was thinking about kind of running this like you give report in the morning. I just felt like to really understand this patient, this would probably be the best way. So I have Jane Doe here. She is a 31-year-old female. She is full code admitted on November 26th. She is a patient of surgical critical care and interventional radiology. She is still critical condition ICU status, but she is stable intubated and post-op from a decompressive craniectomy due to scattered ischemic strokes. So she is still in critical condition. She was brought to the ED after having a focal seizure, which was aborted by EMS with the use of Versed. In the ED, she experienced a hypertensive emergency where her systolic was above in the high 200s. She also had a GCS of 9, so pretty close to that 8 intubate mark. She had a previous history of hypertension. She was an active smoker, had a DNC in 2022, and a history of previous miscarriages. She had no primary provider. She did have an IUD in place, and her toxicology showed no use of drugs or alcohol. Because the patient has been in the hospital for so long, she had so much done, so I'm just going to kind of focus on the more important things. When she first got to the ER, she had they did a few scans and then they decided to do an emergent left side craniectomy and removed a huge hematoma that was causing a left basal shift 4 millimeters from midline and also fixing a common carotid artery dissection. An intracranial pressure monitor was implanted in the patient and she was admitted to the NTICU. When she got to the ICU, she was started on nicardipine, Keppra, mannitol, and other medications to manage her ICP. The patient was intubated on the 26th, had an OG placed, and then on the 29th, they tried again to lighten the sedation meds to perform a neural check to see if there were any issues caused by the seizure. And then when they lightened those sedation meds, she actually ended up having another seizure, which they had to give Ativan and then increase her propofol again. On the third, a cerebral angio was performed to clear out all of the scattered strokes within her brain. And then on the fifth, the patient was able to transition to Precedex for a sedative instead of propofol. A TEE was performed to find the source of the clots, and they didn't really find anything. So to kind of go through the systems here, she had a potassium of 3.6, a mag of 1.6, a hemoglobin of 9.8, and a GFR of 127. So that was really important for us to look at the lights protocol specifically so that we were able to replace her potassium and magnesium. For lines, she had a PIC on her left side, a catheter, an OG at 50 centimeters, and an ET tube at 22 centimeters, 25 with a PEEP of 5. Neurologically wise, she had extreme swelling of the tongue and trace swelling in the eyes. Her Q2 neural checks showed intermittent following on the left side and then only withdrawal to painful stimuli in the right. She had a left eye deviation as well, but over the weekend when we had her, she had small improvements on the right side, kind of spontaneously moving that right side, which was a little different. And then, of course, that Precedex strip was running at 0.5. Um, Her heart cardio-wise, she had a systolic goal of 0 to 140. She was sinus rhythm. We were able to stop her cardian drip and then use PRN hydralazine to keep her within her systolic goals. Um, Her respiratory, her oxygen goal was 94. She had a lot of moderate frothy secretions that we were able to suction from her ET tube. And then she had really coarse lung sounds, which would get better with nebulizer treatments, but then right before she needed another one, when we would go to check her lungs again, they'd be pretty coarse again. GI and GU wise, she had pivot 1.5 running at 45 milliliters an hour through her OG, which was her goal. So we were meeting her nutrition goal. Her last bowel movement was on the 6th, which we used a suppository. Her abdomen was pretty round and firm, which is why we were thinking that she was kind of backed up. So we were giving her a lot of medications to get things moving. She did have audible bowel sounds as well. And then skin-wise, she had a right femoral site that was soft, flat, and dry. She had a left-sided craniectomy flap that was stapled together, which means they took the bone out of her head, where her skull is, obviously, and then they just put the skin flap right back over, which helped release some of the pressure that she was having in her brain. She also had a small abrasion on her tongue from the ET tube. So I included a picture on the bottom right there of a craniectomy flap, just so you would kind of know what that looks like. She was also on flap precautions, which means we had to be extra careful with what we were doing on the left side of her body. And then above that picture, I included a ET tube, which kind of just shows like how an intubated person, what's going on and where that tube is going. Um, she also needed splints on her right side, right arm, and left leg or right leg because she was down on those sides. PT did some passive range of motion with her. And then family-wise, she had her mom and sister bedside. They made the medical decisions for her. For an action list, we replaced her magnesium and rechecked every 2 hours. The goal for her was to wean off the vent. She was able to do it for 6 hours for us, which is a pretty good improvement. And then the next day, they decided since she was able to wean for so long, they were going to extubate with an overall contingency plan in place to trach in case she's unable to secure her airway. Moving on next, I chose the theory, sorry, of unpleasant symptoms because I felt like this really applied to the ICU patients. So basically what the theory of unpleasant symptoms is patients have unpleasant symptoms. Combined, those symptoms make their overall condition worse. So to relieve the overall condition, we need to better the symptoms and treat each one individually. I felt like this really closely related to the ICU patients because they are unable to speak. So as a nurse, it's our job to really look at the symptoms of the patient, what they're experiencing. So using the adult behavioral scale to look at is this patient in pain and then treating that pain. I felt like the adult behavioral scale kind of showed this theory really well because it explains that when a patient is having pain, their blood pressure increases, their temperature increases, everything about the patient just kind of seems to deteriorate a little bit. So to fix this, using the theory of unpleasant symptoms, we were able to treat the pain, which overall then we were able to better manage this patient's blood pressure, and then also better able to get her temperature under control. Um, yeah, I felt like this also kind of applied to a lot of different things within the ICU, just because we are looking so closely at those small little symptom changes. And then overall, I feel like the doctors did a really great job in the ICU of treating each specific symptom and then treating the overall underlying cause. I felt like when people only treated the underlying cause, all of those symptoms continued to get worse and the patient just continued to decline as compared to some other physicians who were able to really treat each symptom individually, whether it be pain, nausea, anxiety, fatigue, anything pretty much. When they were able to treat those overall symptoms, the underlying condition seemed to get a lot better. Um, Moving on. I defined the ANA code as the nurse's promise to keep the patient safe, be accountable for the patient, and then speak up for their needs and advocate no matter what. To me, that's really what Provision 3 meant, and that's what really stood out for me. In Capstone, I feel like the biggest part of this provision that I see is the advocacy part. We are really sitting there every day advocating for the patients because they typically aren't able to advocate for themselves. And a lot of the times the family doesn't know what to advocate for. So, as the nurse, it was really our responsibility to get them adequate pain meds, to get them adequate sedation to where they're not restless and trying to cough up their tube. We were able to get them adequate bowel meds and make sure that their abdomen was no longer getting distended. Um, we were able to really, there's a lot of flexibility in the ICU as compared to more medical floors, where I feel like we were able to really reach out to the provider and say, this is what I want ordered, and this is what we need. And the provider would be like, okay, I see where you're coming from. I understand what you just said. Here's the order. And then we were able to kind of really speak to what we wanted as the nurse and what we thought would make the patient better. And then the provider would order it for us, which I felt like was a lot different than other floors I had been on previously. Um, a specific example, I feel like again, just getting those adequate pain meds. We had a patient who was in a lot of pain, had necrotizing fasciitis all up his arm, so no longer really had skin on his arm. We had to really advocate for the pain meds because the doctor was not giving us enough. And then overall, I want to take this provision into my practice by really advocating for the patient and what they need. We are able to watch them closely, so we're able to really see what they need. And so it's our job to really advocate to get those needs. And then overall, just using my safety checks and keeping the patient safe. And then here are the two sources that I used. And thank you.